Welcome everyone. This is Dr. Jaitly, your cardiologist from New York on your favorite site, MuniMeterHealth. And as you know, we are featuring on several social platforms and mainly to enhance the medical education and of course the patient education simultaneously on the same websites. And this is in order to improve the clinical outcomes, as you all know now. And in fact, we are probably reaching out to the world, and everybody is now on their smartphones. And I thank you for connecting with me on your tablets, your computers, and your laptops. And here I am, and I feel that the entire world is like a classroom with me right now, learning as we progress. So I'm extremely happy to be associated through this medium directly into your home, into your offices, and therefore we can connect and talk. So without any further ado, like I always delve into the subject matter right away. Again, this is a teaching educational site only. There are no medical emergencies that we can handle here, obviously. And at the same time, we do not consider this as a substitute to any syllabus. So medical students and residents and fellows, please mind, this is only a supplement to your syllabus, which you have been advised from your universities. So having said that, let's understand what bradyarrhythmias are, because I've done a video vignette on tachyarrhythmias. So therefore, this is pretty much a follow-up on that. Now, first degree AV block. Well, what is bradyarrhythmia? Obviously, the heart rate has to be less than 60. Anything more than 100 is considered as a tachycardia, obviously, so which we have discussed on the previous one. But just so that you know, the heart rate has to be less than 60 to call it a bradyarrhythmia. Now, invariably, what happens is if it's a simple sinus bradycardia with no prolongation of any intervals, it'll be called sinus bradycardia. But generally, what happens is there will be other stigma of bundle branches or perhaps even the AV conduction blocks that can exist. Now, we know there are three types of AV conduction blocks. One is first degree AV block where the PR is prolonged. Now, PR is the interval where the atria are depolarizing, and it's the onset of the QRS, which is the ventricular depolarization right here, and that becomes your QRS, and this is your P wave. So this becomes your T wave. So the interval between the P wave and the onset of the P wave to the onset of the QRS is your PR interval. So essentially what you're looking at is you're measuring the PR interval from the time between the onset of the P and the QRS, and that gives you a rough idea as to where the PR interval is. Normally it should be less than 0.2 seconds. When it's more than 0.21, it's considered as abnormal, and that is abnormal first degree AV block. So that's very simple. Okay, now you have what it looks like is a second degree AV block. A second degree AV block normally implies a Wenckebach or a Mobitz II. So there are two types, as you know. So Wenckebach phenomenon, which is also called Mobitz I, if you will, but normally just to distinguish and not to confuse, Wenckebach phenomenon is PR prolongation till a drop beat occurs. Remember, there is a drop beat. Now, here I've shown you in this complexes, for instance, you have a P wave, a P wave, a P wave, a P wave in the reds. And the QRSs obviously are shown in the blue. Now, you notice how the PR interval is prolonging here versus here versus here. So as you see, the PR prolongation between the beat 1, beat 2, and beat 3, and then of course there is a fourth beat where there is a drop. So this is your drop beat actually, and we have not shown it because there is no, why is it called a drop beat? Because there is no effective QRS, and therefore there's no effective ventricular depolarization, so there is no pulse actually also. So you'll miss a pulse here, if you will, to check the pulse there peripherally. Okay, so this ratio is 4:3. Why 4:3? Because 4 P waves, 1, 2, 3, and this was your fourth beat, which was blocked or a drop, and the QRS and the PR prolonged till there was a drop beat. Wenckebach phenomenon. That's the second degree AV block. Mobitz II, on the contrary, has a PR which is unchanged but a sudden drop beat. Now let's quickly draw that. So you have a P wave. We're doing in the same color though, by the way. So, and then you have, say the PR is like this, and you have a QRS like this. And then you go, and then you have a P wave, and then you have a QRS like this. And then you have a P wave, and then you go, and then you have a QRS like this. And now, suddenly you have only a P, and boom, there's a drop beat. So the ratio could be 4:3, 5:4, or 3:2, depending upon how many beats have conducted, and then there's a drop beat. So this is again a drop beat. But here you notice the PR, even though I drew it, is a little different. But imagine the PRs are constant here. So that's very important. The PR is constant, and constant here till there is a drop beat. A third degree AV block, I've shown it here now, very, very important, where the atria and the ventricles are independently in their rates. They're going about in their own rates. So the atria don't know what the ventricles are doing, and ventricles do not know what the atria are doing. So the P and the R's are not related or conducting at all. And it's called, in other words, an AV dissociation. Why? Because P's, for instance, here, this is a P rate, a P rate, a P, and a P, and a P. So that's the P rate. But the QRS rate is somewhere here. Look at that. So it's not that the P is conducting into this QRS. It just happens to be that this QRS is between these two P waves. This QRS is more closer to this P wave, you notice that? And this QRS could actually be overlapping this P wave, if you will. Pardon me. So ventricles are beating at different rates. This is your RR interval, and this is your PP interval, if you will. So the PP interval is much different than the QRS, the RR interval, if you will. And none of these R waves are actually conducting via the P waves. So in other words, no P is conducting into a QRS. So that's an AV dissociation, okay? So in a nutshell, you learned the first degree AV block, the second degree AV block, and a third degree AV block. It's a quick revision for the medical students so that they know that the PR, if it's more than 0.2, that's considered as borderline until 0.21 and 0.22 above. And if it is 0.22 above, then that's definitely a first degree AV block. Some people consider this as a borderline AV, but I by definition, I think anything more than 0.2 should be considered as first degree AV. Wenckebach, here the PR prolongation till a drop beat. Mobitz II, where there's PR is unchanged but a sudden drop beat. Now this is rather very, very serious. Remember, this is considered as, because you don't have any warning whatsoever. So it's considered as a very serious, and in fact this drop pause can continue and patient can pass out. So this is very important that Mobitz II, again, it's beyond the scope of our video discussion here because we are just discussing the rhythm strips here. But the treatment plan here would be, this most likely would require a pacemaker, okay, just so that you know. Any of these can require pacemaker if they are symptomatic, but pacemaker and a Mobitz II, even in asymptomatic cases, will require a pacemaker because this is a very, very serious condition. And likewise, a third degree AV block will also require a pacemaker, especially if it is permanent. It's not a temporary rhythm. But the very fact, we'll discuss the treatments in different videos. I have discussed in other videos, but this is basically, we are discussing only the rhythm strips here. Okay, so again, on MuniMeterHealth, we'd like to improve the medical education and patient education, as you know, to enhance the clinical outcomes, and that's one of our goals. And thank you for being on all our social platforms. And again, we are on the social media as video channels, cardiology video channels, primarily gearing towards medical fraternity and the general masses at large. So this way we can improve the clinical outcomes both by educating the doctors as well as the patients in general. Okay, thank you again for watching MuniMeterHealth. This is Dr. Jaitly from New York. So